Good evening, everybody. Thanks for joining our second session of AO North America Link 3.0 on Thursday, August 14th. We're going to be talking about fluoroscopic and radiographic imaging, tips and tricks, and how to get the right shots. So before we delve into the details of this presentation, just a couple introductory slides. These were covered in session one, but these are things that we would like to emphasize and kind of re-highlight for everybody. So one of those being Fracture Friday. This is a collaboration between AO North America and MSOS. Stay tuned on Instagram every Friday for bite-sized orthopedic trauma cases and education to happen. Here also is a QR code that you can use to log on and become a student member of AO North America. I'm told it's free right now, so please take advantage of this opportunity. What is AO NA Link? So if you were here for the first session, which happened a month ago, you got a little glimpse into what this is. But in brief, this is a year-long medical student-focused education series sponsored by AO North America. It highlights a lot of orthopedic trauma care and educates medical students in this realm. Like I said, it's going to happen over the course of the year. We have 10 scheduled lectures and probably a few bonus lectures in there for some added content for you all. We would like to take a brief moment to recognize and thank the leadership of AO North America, including Dr. Lee and Kapatkin, for supporting this mission and AO Link, and also recognize Dr. Aker, who is kind of the founding member of this very important educational platform. So tonight you'll be joined by myself, Lucas Marchand, faculty. I'm an orthopedic traumatologist at the University of Utah and also the co-chair of AO Link 3.0, Pat Kellum, who does trauma at the University of Texas Health Science Center at Houston. And we are pleased to invite tonight past chair Taylor Young, who will be here, as well as Lilia Stephenson, who will be our primary guest tonight that will sort of pick her brain and get a bunch of knowledge from Lilia. She is an assistant professor getting ready to start a new job at SUNY Upstate in Syracuse, New York. So welcome both Dr. Young and Stephenson. We appreciate you guys joining us tonight, and I'm sure we'll all be smarter for it. Here's a quick list of disclosures for the two chairs of AO Link 3.0, Dr. Kellum and myself. So here we're at. We have 10 total sessions planned, like I said, and perhaps a couple bonus sessions to help you guys during the interview season. We're on lecture 2. If you missed lecture 1, which happened on July 17th, about how to leave your orthopedic rotation well liked, you can look for a video of that on YouTube. And here's a list of up and coming lectures that we're excited to share with you all. Be sure to visit AO Milestones. You can visit this through the QR code listed here as well, which can give you an individualized learning experience and work through AO, some additional education there. All right, just some brief etiquette. Please make sure all microphones have been muted and your video cameras are turned off. Send in all questions or technical issues through the Q&A box. This will be monitored throughout the presentation. Dr. Kellum is going to do a good job getting back to any questions you may have as I run through the slides and sort of moderate this session. And the chat box is only for faculty and staff to work through any technical issues on our end. So please, again, direct any questions you have to that Q&A box. And don't be afraid to use it. Only a handful of questions through that first series. We want this to be interactive and educational for everybody. Earn a merit badge in fracture management. We'll talk about that at the conclusion of this presentation, but essentially look in your email for a Zoom link that will allow you to rewatch this session. You can also look for this session on YouTube, and also you'll get an email that will allow you to claim your Credly badge for this session. If you get Credly badges for all 10 sessions, there's going to be a special prize at the end. So again, here we go talking about imaging. Dr. Kellum and I had reached out to a bunch of people, including current, past residents, and even med students. And this was a topic that garnered a lot of interest, was just talking about radiographic imaging as it is sort of the foundation of the language we speak in orthopedics. And hopefully we'll give you a generalized overview of this and make everybody more comfortable with the topic at the conclusion of this presentation. So objectives today, we're going to identify what a perfect AP and lateral view of each major extremity joint is, specifically the shoulder, the elbow, the knee, and the ankle. We're going to skip the wrist for today and also the hip because we're going to come back with a dedicated hip series later on in our lecture series. Then at the conclusion of this, we'd also like you guys to be able to describe fractures and dislocations of these joints and start to appreciate soft tissue and other structures on radiographs. So to sort of look at the periphery of the radiographs and not just be so focused in on the skeletal anatomy. Why is this important? Well, understanding how to read radiographs demonstrates an understanding of the anatomy. So reading radiographs and understanding what you see on radiographs really calls back upon your basic anatomy knowledge base. Additionally, oftentimes in the operating room, we can use contralateral images of an extremity to get a template for how to fix a broken bone. But that means you've got to get perfect images of the other extremity if you're going to use those as a template to aid you in reconstruction of an injured side. All right. It will also help you avoid missed injuries if you know what a radiograph should look like. And like I had alluded to earlier, really talking about x-rays is the foundation of orthopedic language, and it's a really important skill for us all to master. And it's a good thing for medical students to really begin honing in on early in their careers. So let's kind of dive into the nitty-gritty details of reading radiographs. So for most limb segments, there are two images that we're always going to obtain, either an AP or a PA. So this is basically the coronal plane view, or looking at the extremity or body segment head on, and a lateral or a side view. Depending on the joint, there are also a series of specialized views that you can get both intraoperative or pre and postoperative that will allow you to evaluate special components or characteristics of those joints. So let's go through these, and then we'll get Dr. Kellerman Stephenson really involved in the discussion as we work through a couple of cases for you all. So the first joint I want to talk about specialized views on is the shoulder joint. So the shoulder joint includes a couple specialized views, such as the top-down view, which is really a view to look at the clavicle, the Grashy view, which is an offshoot of the AP of the shoulder, where you're looking right down the glenoid, and we're going to see some examples of that in the coming slides, as well as a scapular Y view, which allows you to basically look at the glenoid enfosse and also discern whether or not the humeral head is in a located position. The elbow, which gets an oblique view, the wrist, where you get a DRUJ view or horizon view and a scaphoid view that allow you to evaluate different components of that. Again, we're going to leave wrist out of the conversation for the most part today, as well as the hip, but there are other views that we get in a hip besides an AP and a lateral, such as a cross table or frog lateral, internal rotation views, and then a host of views that allow us to evaluate the pelvis and acetabulum. Names that you've probably heard would be Judet views or inlet and outlet views. Again, to be covered in a future talk from AO Link 3.0, so please stay tuned for that. Then in the knee, you can get a sunrise view, which allows you to evaluate the patella, a plateau view, which we'll talk about later in the presentation, that allows you to look right down the joint, or a PA flexion view, which is something you may see obtained in adult reconstruction or arthroplasty clinics, as it's felt to be the most sensitive view to diagnose osteoarthritis of the knee. Then in the ankle, you typically get a mortise view, which is a slightly internally rotated view, which allows you to see down the medial gutter of the ankle, and is something we're going to go over in detail later. And the hind foot, which won't be covered today, has a litany of specialized views that allow you to evaluate certain components of the hindfoot, such as the Harris, which allows you to look at the calcaneal tuberosity, canale view, looking down the neck of the talus, a Broden's view, which gives you a good look at the posterior facet of the calcaneus, and finally a hindfoot view, also known by its eponym, the Saltzman view. Okay, and then in the midfoot, you typically get three views of the midfoot, one of them being an oblique, very similar to what you see in the elbow. So, reading x-rays. Dr. Stephenson, would you mind going over this slide and just giving us an idea of what are the basic terms we use reading x-rays and give us an idea of really what your process is? Because in my mind, reading radiographs is truly a process. Give us an idea of what your process is when you're looking at a plain film radiograph.
Yeah, so when I'm first interpreting a series of radiographs, I'm taking into consideration which views have been provided. Additional views might be a benefit for interpretation. And then I start, kind of down this list in this agreed upon organization and how we communicate about radiographs or fractures. So, what are the views that have been provided? Where is the location of the injury? Where does it extend, whether it's solely extra-articular or if it extends to the joint surface? And then I start to go on to describe the pattern of the fracture, the displacement of the fracture, and then potentially um, disruptions to the articulation, so dislocations or subluxation of the joints that are in view. And then what's listed last, but I think is very important, is you can learn a lot by looking at the soft tissue shadows on the radiographs. So whether that's air in the soft tissues, or even sometimes you'll be able to see the silhouette of some like gauze or lap sponges that have been placed on an open wound, which can tell you where the soft tissue injury is. And then once I've gone through all this, as I'm saying it, I'm starting to think about, additional imaging, next steps, and this is a good pattern for medical students to get in the habit of doing so that they can respond, in whether it's conference or just in clinic and communicating with the rest of the team.
The other thing I think that in the soft tissues is you can see tourniquets on extremities. The soft tissue shadow will kind of become an hourglass, and you can actually see the outline of a tourniquet, normal ones that the EMS folks use, which can clue you into certain things for the patient when you're trying to go down and evaluate them when you've just looked at an X-ray before you've seen them. So it's all just little clues for you to prepare yourself when you get down to the emergency department or in clinic or wherever you are.
That was great. Thank you both. I think another thing you can see, Pat, that's something, again, just giving ourselves a little plug for future link lectures. Another thing you can see is certainly in the pelvis is the presence of a pelvic binder, which may clue you into what EMS was worried about when they brought the patient in, or perhaps the emergency department. So as Dr. Stephenson said, I believe that this is a great framework to work through. It flows very nicely, at least in my mind, of a good way to describe a skeletal injury. All right. And we're going to get several examples of having both Dr. Kellum and Stephenson walk us through what they see on plain film radiographs using this framework and this language as an example and a goal for all of you to work toward as you move through your sub internships and internships following matching. Dr. Kellum, what does this mean? Single view equals no view.
Yeah, so one of the number one rules we like to talk about and looking at radiographs is one view is no view or a single view is no view. It just means that you can evaluate an extremity or an injury or a fracture or anything when you only have one view, either an AP or a lateral. If you only have one of them, I didn't put an example in here, but I really should have now that we're talking about it, of an X-ray that looks perfect. I actually fixed a fracture on Tuesday, a subtroch where we pulled traction, and on the AP it looked like it was perfect. And then you came to the lateral and it was about 6 inches displaced on the lateral, and so you just can't get a total understanding of the injury or the fracture without seeing an AP and a lateral, or we like to say oftentimes orthogonal views, 90-degree views that show you the two different planes of the injury.
Exactly. So anytime you're getting consulted about something or you're trying to evaluate whether or not a joint is located, you've got to have multiple views to evaluate. How about this, Dr. Stephenson? Bad information equals bad results.
Um, I always talk about how being a good orthopedic surgeon, you have to also be like a good radiologist. So understanding what makes something a good or correct image is critical in order to be able to get the information that you want. Because if you have a poorly rotated film or just an inadequate view, you really can't make any type of diagnostic conclusion from it. It's like, we all learn how to spell the alphabet when we're kids. And if you don't follow the convention of how does this letter appear, no one can interpret your writing. So you have to, be active in trying to obtain good x-rays, whether that's in the emergency department or especially in the operating room, so that you can interpret what's going on.
Yeah, you absolutely need good information to make good decisions. And I kind of love the analogy you brought in there about handwriting. That was awesome. So, just briefly, before we get into the four joints that we're trying to really go do a deep dive into today, again, the shoulder, elbow, knee, and ankle, I just wanted to bring up for you all the presence of diaphyseal fractures and imaging diaphyseal fractures. So, this would typically be when you're like ordering images of, say, the humerus or the femur or the tibia. When you do that, you typically are getting two views of that long bone. So on this slide, we see an AP and lateral radiograph of the humerus. So ordering images of an entire long bone segment, you usually get just APs. Laterals, those usually come in two or maybe four images. The reason why you may get four images is, say in the femur, if the femur is long enough, they may not be able to fit the entire AP or the entire lateral on a single flat plate film. And so you'll get like an AP of the proximal femur, an AP of the distal femur, then a lateral of the proximal femur, and a lateral of the distal femur. But ordering and interpreting diaphyseal films is rather straightforward. And thus, we chose in this presentation to really hone in on the joints kind of above and below the long bone segments that are most commonly injured for you all.
I think the other thing, Lucas, just to mention just briefly, is don't expect to get a perfect image of the joint, a proximal or distal portion of the joint on your diaphyseal images, right? I know the humerus one I was just looking at, and it has almost a perfect lateral of the elbow and a perfect scap Y of the proximal of the shoulder on the lateral, but that's not necessarily what you're trying to look at. You're trying to look at the shaft, the diaphysis portion. So you just need orthogonal views. Don't expect to always get a perfect joint of above and below. That's okay. You need to get dedicated joint films if you want to look at the joint.
Exactly. And that brings me to actually interpretation of this radiograph, which I was hoping Dr. Stephenson could walk us through. Just a quick interpretation of these diaphyseal films of a left femur.
So we have AP and lateral radiographs of a left femur, which demonstrates there's a multifragmentary diaphyseal fracture of the femoral shaft with medial and posterior translation. Um, and like I was talking about earlier, this is where we like, and what Dr. Kellum was saying, the lateral knee radiograph is not ideal because it's a diaphyseal film. And so if we want to look for associated injuries, we start thinking about getting dedicated films of the knee to follow, and then additional films of the femoral neck potentially.
Yeah, I think you make an excellent point there. That's kind of a throwback, I would say, maybe to one of the older link sessions that you guys can find on YouTube, where Phil, Dr. Mitchell, he described a classification based on his favorite X-ray tech. It's this guy, Walter at Vandy. Walter's a bit of a hippie, but he's an excellent radiology tech. And so it was a good way to remember things. But you described it perfectly. You said, what is the image? Is the first thing in that Walter classification. Then it's age of the patient, which isn't always relevant, but sometimes is relative if there's growth plates or something like that, or really poor bone quality that can give you some clues about things. And then location of the fracture, like you said, a diaphyseal fracture. In this case, it involves the femur bone. And then the type of fracture, you said multifragmentary or comminuted fracture. And then you can use all those descriptive terms that you said before. And then where does it extend to? And then looking for, like you said, associated injuries. And in this case, obviously, we all know, but so the students know that probably if you're asked about this on a rotation, you'll probably get some bonus points if you say, oh, then I want to look at the femoral neck to make sure there's not a femoral neck fracture because there's an association with femoral shaft fractures with femoral neck fractures. And depending on the institution, I know Patrick's getting an MRI to see if there's a femoral neck fracture, but a lot of the rest of us are getting fine cut CT scans. I don't know. What do you guys do at Utah, Lucas? You guys in the MRI crew?
We're still doing the fine cut CT scans. That work that came out of Houston and Dr. Kellum's group's very interesting, but I don't think super practical at many institutions, ours being one of them. So we're still getting fine cut CTs, and I think we're doing a good job. In my 5 years here, we haven't had a missed femoral neck associated with the femoral shaft, so that algorithm does seem to be working for us.
What about you, Lilia? What do you guys do? Or what were you doing at Harborview, maybe?
We typically utilize our trauma CT scan, which is fine cut pelvis CT. Um, MRI is not really utilized in the emergency situation. And then we, use our intraoperative checklist to make sure there's no occult femoral neck fracture after that.
Yeah, we're the same. We're the same.
I'll make a plug for the MRI. I do have a patient who got a cut CT because they were too large for the MRI scanner, so they were unable to get an MRI, and their fine cut CT scan was negative, and they did have a femoral neck fracture.
Just as an aside, I'm always curious, like, how does that logistic work for getting MRI screening sheet done in the trauma patient?
They do it. They do the screening sheet pretty quick. It was kind of a big deal, but it became quick. And it's only a coronal image. It's one scan. It's just a coronal image, or there's two coronal images, and then one's a stir. So it's not like a full MRI. It takes like 7 minutes for them to do it. It's a quick one. And I think it seems like we have 42 MRIs here because everyone seems to get them overnight. So it helps to have the system built in, but out of the purview of the talk. We can keep going.
Yeah, if people are interested, though, would encourage you to go ahead and read that work out of UT Houston, looking at the utility of MRIs to diagnose occult femoral neck fractures in patients with diaphyseal fractures of the femur. So a couple things that I wanted to bring up just very specifically as it pertains to this radiograph that I loved that Lilia described is she described that medial and posterior displacement of the fracture. That's because she's describing the displacement of the distal fracture fragment relative to proximal. And that's commonplace nomenclature when describing injuries. So when either describing displacement of a fracture or displacement of a dislocation, you describe the displacement of the distal segment. So the distal segment of the joint or the distal segment of the fracture. That was great. And then it has been highlighted, but I will just additionally reiterate, evaluating the joint above and below long bone injuries is very commonplace and something that we typically do with dedicated radiographs in an effort to really hone in and get good images of the knee, or like in this case, of the knee and of the hip. Because just getting the basically diaphyseal or long bone femur films doesn't allow us to really hone in on the granular detail of the knee and the hip, the segments, the joint segments above and below the injury. So we're going to move into the case-based portion of our discussion, which I hope brings about as much discussion as just those plain films of that femoral shaft fracture do. And we're going to start off with a 53-year-old male who is injured in a motorcycle crash that is reported to have multiple extremities injured. And Lilia, Dr. Stephenson, gets this page. She sees the patient's MRN, pulls up some radiographs, and this is the first thing she sees. Her attending happens to be sitting next to her, but not looking at her screen. And so she's asked to describe these films when she was a resident to the attending next to her. What would you say, Dr. Stephenson?
An AP and an axillary view of the right shoulder demonstrates a short oblique metaphyseal fracture of the proximal humerus with what looks to be lateral translation and potentially some rotation, but the glenohumeral joint appears concentric and well reduced.
Awesome. That is such a great description. And the thing that I really want to point out to the medical students, because you guys are going to get asked all the time to interpret radiographs, again, like either in clinic, either on call, or in conferences, educational conferences that you're at, how succinct that was, yet how much information she relayed to us. She hit on all the critical points, and it was appropriately done. Kellum, is there anything you would add to her description, or are you satisfied with everything she said?
I'm really satisfied with everything she said. The what is really nice about the way she said it, she focused on the injury. You can in your back of your mind what all of us on the panel are doing is we looked at everything else on the image, and I know you're going to get to that when we get to the shoulder, but we looked at everything else that was negative. I think the other thing to notice is that this person has a fairly large chest soft tissue envelope. The white haziness extends over the portion of the arm. You can see kind of overlapping whiteness here. And then the shoulder, this gets a little bit getting used to how big a shoulder looks like on an x-ray, but you can just tell this person has either muscle mass or is a large body habitus. That would be the only other thing that in my mind I'm going, wouldn't put that in the description, but in my mind I'm looking at that and saying, okay, this person's a little bit bigger. I'm gonna take Rodrigo. Can you ask that question again? I clicked the wrong button in the chat. If you can just do it, I'll type you the answer. But I hit the wrong button. Sorry.
So we're going to talk about this in
I
the
can answer it, Pat. I'll type a quick answer there.
Okay, perfect. Thanks.
we're going to answer this or talk about this, excuse me, in the coming slides, but this is an axillary lateral of the shoulder, just as Dr. Stephenson described. And we're going to talk about the other laterals you can get and the utility of them. So as he'd mentioned in the opening slides, in addition to having an AP view of the shoulder, there's this sort of specialized or oblique AP view called a Grashy view that we'll show here in a second. And then there are a couple different laterals you can get. So either an axillary lateral like we saw in the last slide, or a scapular Y view that you saw Pat refer to when we were looking at the AP and lateral of that humerus earlier. But I'm going to show you a dedicated scapular Y view of the shoulder here coming up. So this slide really highlights the difference between an AP view of the left shoulder and a Grashy view of the left shoulder. Do you want to walk us through this, Dr. Stephenson, the differences between these images that are obvious when you're looking at them, but I think it's great for somebody to kind of describe what they're seeing as a difference between the two images and why a surgeon or a resident may obtain one view versus the other?
So the image on the left is an AP of the shoulder, and you can see it has a very good AP profile of the proximal humerus, as well as the AC joint. You can see very clearly right down. The difference, the image on the right is the Gracie, is that it's a um, view at a like 20-degree angle, so you can look directly down the glenohumeral joint. And so that's very helpful to visualize fractures along the glenoid surface potentially, and really give you a better idea as to the position of the articulation between the scapula and the humerus.
Yeah, exactly. This is a crisp look down the joint surface of the glenoid, that Grashy view, and the AP is sort of oblique to the articular surface of the glenoid, and it gives you this more en face look. And obviously, as you change the rotation and you see a different anatomical perspective of the glenoid, you're also seeing some changes in the proximal humerus, where the greater tuberosity of the proximal humerus may become more or less visible. And again, you see on this Gracie view, you get a different view of the clavicle, and you don't get such a good view of the AC joint like Dr. Stephenson had pointed out on this AP view. So here's just like a schematic representation of the functional differences or the mechanical differences in which those x-rays are obtained. So this is an axial cut of a CT scan of a proximal humerus fracture. And we're just trying to depict the radiographic beam here shooting basically non-parallel to the glenoid. So this would be how you obtain that AP view. That's why I'm going to go back a slide. You get this sort of en face, not perfectly en face, but more of an en face view of the articular surface of the glenoid. Contrast that to the same axial cut of the glenohumeral joint, But now we've internally rotated the beam and we're shooting that beam parallel to the articular surface of the glenoid, which gives you this more crisp view that you see on the gray sheet. So just a couple of things to look at very specifically anytime you're evaluating a shoulder radiograph. If we're looking at the proximal humerus specifically, you're going to look at the proximal humeral head, the lesser tuberosity, which is identified here by this circle and really represents this additional radiographic density kind of in the central portion of the humeral head. The greater tuberosity, that's where your supra and infraspinatus attach, and obviously the lesser tuberosity is where your subscapularis attaches. So important to understand again the anatomy and why these anatomic locations are important. And then this is a gray sheet view of a right shoulder, but there's something different. I want to cue you in on looking at the proximal humerus. Dr. Kellum, did you want to give us a little bit of a description of what you're seeing with these two contrasting images?
Yeah, so it's the view of the scapula hasn't changed between the two images, but the proximal humerus looks different. That's just some internal and external rotation of the proximal humerus that compared to the image on the left. But you can see here on the image on the left that there's a 1 to 2, 3 millimeter depression on the lateral portion, the outside portion of the proximal humerus. That's a flat insertional portion of your rotator cuff, the infra and supraspinatus, like Dr. Marchand said. And that's a classic AP of your proximal humerus. Sometimes it can be confusing because the joint has so much range of motion and degrees of freedom of what the actual proximal humerus AP is. You should be able to see a clear differentiation of the articular surface and the greater tuberosity, as well as the articular surface. So the image on the left, I would consider to be a perfect AP of the humerus, while it's a Gracie view of the shoulder.
Awesome. That's a great description, and I think very educational to see these contrasting images side by side. And then here's a look at those two specialty lateral views. Dr. Stephenson, do you want to walk us through these?
Yeah, so on the left is the scapula Y view. And so it's a very good profile of the scapula with the humerus kind of overlaid on top. In contrast to the image on the left doesn't give you the same perspective in terms of the joint surface. And so that's why you'll often hear the residents who are taking call from the ER asking for not just the scapula Y view for lateral, but also the axillary lateral that's shown on the right, because it really allows you to visualize whether there's any subluxation of the glenohumeral joint.
Yeah, I
Yeah.
find the
Shows you the
scapular
acromion too, and like the coracoid in a different perspective. So
Yeah, I find the scapular Y view, very helpful for the scapula, but very unhelpful for the shoulder, if
I
that makes
agree
sense for
completely.
people. Yeah,
Yeah, I think one important thing is to note, like when you're looking at the shoulder, how important that axillary view is, because not infrequently you may get a consult from the ER where they said, "Oh, it's just like totally benign," or they show up in your clinic later and it's dislocated because they didn't get an axillary view, and so the axillary view is critical. Another option is a Valpo view. I don't know if you guys are going to touch on that, but the other thing I might say is that. If absolutely there's some concern for a CT scan and for whatever reason you can't get a good axillary, sometimes a CT scan may be your best option. I don't know. What do you guys, is that like a big no-no where you're at, or what do you guys think about CT scans in certain fractures and things to make sure that the glenohumeral joint is reduced?
So for me, if there's any concern or I'm not getting orthogonal views, so to prove a joint is in a located position, we're going to go back to those orthogonal views that Dr. Kellum had mentioned. You've got to have orthogonal views, and the joint needs to be located on both of those views. That's kind of what you need for definitive proof of a joint being located. If I'm unable to get orthogonal views for any reason, and the primary one would be that of patient discomfort, then I have a pretty low threshold to go to a CT scan. There's obviously added expense of the CT scan and radiation exposure, so we don't love either of those things. But if it's necessary and you can't obtain the radiographs to feel comfortable with, then I have no qualms about going down that road.
agreed.
And then Dr. Stephenson, I think Dr. Young brought up something kind of interesting, which is fractures, do you just want to, in general, I just take a moment to step aside from shoulder specific discussion right now and just say, in general, what are your indications for getting CT scans? Just because it was brought up, I think it's an important point to note. Like, these are the times where I like the plain film radiograph is helpful, and then I need the added information that a CT scan is going to provide.
I think a lot of the value of CT scans come from fracture patterns where you know there's a reasonable incidence of associated articular fracture, or that there might be extension to an articular surface that would change your implant choice or your approach to treat the fracture. So like a good example is a spiral distal third tibial shaft fracture that might have a very difficult to visualize extension to the posterior malleolus, or there's a proximal tibial shaft fracture that there's a questionable line that I really can't interpret on radiographs as to be, a true fracture line extending to the joint surface that would change how I approach the injury. But also like fracture dislocations where I really want to understand the relationship of the fractured portion and the, like in this case, I think there's actually a surgical neck fracture on the image on the left. If you were concerned about, like, is there an associated bank heart lesion on the glenoid? Those would be other times.
Yeah, I totally agree. Times where you're worried about associated injuries that you know have a prevalence with whatever fracture you're evaluating, or there's frank joint involvement that you're trying to get better detail on. Those are kind of two primary reasons why we're adding CTs on. Here's a look at the humeral head again on this axillary lateral and the tuberosities. Just want to point those out for you guys. And then showing you some post-op films from that initial radiograph that we interpreted, just because showing you a fracture without the fixation strategy is like having dinner without dessert. We're going to pepper these in for you guys. And then I just wanted to take a brief moment and use this as an opportunity to emphasize the fact that don't just get focused on the fracture you're looking at or the specific body segment you're looking at when you're reading x-rays. Like, we just spent 10 minutes talking about basically the proximal humerus because that was the fracture we saw on that initial radiograph. But on those x-rays, you can also see the AC joint, the coracoid of the scapula, the articular surface of the glenoid, and the scapular body, in addition to the clavicle, right? And we also are seeing some ribs and a lung field, which I'm not great at interpreting, whether or not there's a presence of a pneumo. But it is something when I do have images like this that I'm at least making note of when I'm going through the radiograph. So don't in isolation look at the segment you're interested in or just the skeletal injury, because that is a recipe for missing something important. Consult number 2, 38-year-old male fall from scooter with right arm pain. You pull up the radiographs, Dr. Stephenson, and boom, what do you see?
So there's an AP and an oblique or lateral of the right elbow, which shows a comminuted intraarticular distal humerus fracture with what looks to be varus angulation. And also you can kind of see on the AP projection, but is better seen on the lateral attempt, that there's a radiocapitellar dislocation, it appears.
Dr. Kellum, next steps of evaluating an injury like this in the emergency department. Dr. Young had just mentioned CT scans. Are there any other x-rays you would obtain for this? And would you order a CT scan? And if so, why?
Yeah, so I think the one X-ray you're trying to get me to say is a traction view. So that's where we apply axial traction to the limb, and it uses, we call ligamentotaxis, or uses the ligaments to provide some reduction aid to the humerus and give you the distal humerus and give you some idea of what the fracture, because sometimes this just looks like a bag of bones and you don't really know what's going on. And if you can pull some traction, you get a better idea and you don't need a CT scan. However, for this, I think I see a fair amount of trochlear comminution, or multifragmentary fracture in the middle part of the joint. And so for this, I want a CT scan to know how many fragments are in there, where exactly the fracture is along that articular surface. And then is there any hidden comminution for the metadiaphyseal reduction here proximally? So that's what I want. Sometimes there can be some subtle fractures of the radius and ulna, but that's what I am ordering a CT scan for this.
And Dr. Young, what I'm going to pull you into the conversation briefly, is there anything or any special like reconstruction of the CT scans that you get at your institution that helps you better interpret these injuries? Or is just a standard format of the CT with a coronal, sagittal, and axial cut good enough?
Yeah, I mean, I'm a little bit spoiled by the imaging platform we utilize, and I'm probably more reliant than I should be on 3D reformatting because I think that it's just so incredibly useful. But in general, I don't ask for anything specific for the reformats. As long as they have a CT scan here, I can just press Control T and then I get 3D images, and that's been super helpful. So I'm spoiled in that way.
Yeah, I was kind of hoping you would say that because I do find those 3D reformats, or what you'll sometimes hear people call surface rendered image, is super helpful for complex interarticular fractures like this, especially in the elbow, because getting the reconstruction of a perfect coronal, sagittal, or axial cut is very challenging. But as we continue to talk about just plain film radiographs, we had mentioned earlier, there are typically three views of the elbow. We get AP, lateral, and oblique views. This is what they look like. A good lateral of the elbow has, we're going to talk about here in a few slides, but has a nice look at the um, proximal ulnohumeral joint, as well as demonstrates a nice alignment of the radius relative to the capitellum. The capitellum is identified by this near perfect circular structure when a good lateral is obtained. Then you get an oblique and AP views. They give you slightly different profiles of the articular surface of the distal humerus as well as the medial epicondyle, as you can see contrasting here. But again, we're looking at the articular surface, the capitellum as highlighted here, the shaft of the proximal humerus, the articular surface of the trochlea, as well as the medial epicondyle. So when we're looking at distal humerus fractures, those are the things we want to look at. And then this area of sort of radio opaqueness is the olecranon fossa, or the area of subtracted bone we all have in our distal humerus that allows our ulna to articulate. Dr. Kellum, did you want to give us a description of this slide and exactly what it's demonstrating?
Yeah, so I think when medical students and residents, junior residents are in the ER and they're getting fluoro shots on a mini C-arm, the two joints that can be really difficult for them to obtain laterals of are the ankle and the elbow. And the elbow, because it's complicated, there's you think you have a lateral because you have one circle, but there's actually three concentric circles in the elbow. And this slide really nicely shows that, there are three circles that are over superimposed, but they're at different sizes. And so the capitellum is kind of in the middle. The trochlear sulcus, or the end of the trochlea and the middle portion of the distal humerus, is the most inside, and then the trochlea is the largest of them. But if you get a perfect lateral, you can see all three, but they should all be concentric with each other. So this is just a really nice image showing what the true lateral, the distal humerus is. And I think we'd be remiss to say, if you can go back a slide, that the radial head and the proximal radius should always point towards the capitellum. There's a fracture called a Montasia fracture, which is a proximal ulna fracture, where the radial head dislocates. And so whenever you look at an elbow, one thing you should always do, there are many things, but the one thing you should always do is make sure the radial head is located. And it should always, no matter what image, it can be the worst quality, worst positioned film, it should always point at the capitellum.
Fantastic. Here's your dessert with that complex interarticular distal humerus dinner fixed beautifully by Dr. Kellum.
You're a wizard.
No.
All
No.
right, Dr. Stephenson, we're back. You're back on the pager. You only got a brief break, and now you've got a 38-year-old male ski accident, twisting injury to the right knee. What do you see?
AP and lateral of the right knee demonstrates what looks to be depression of the lateral plateau. Other things I look for on these films is it's a very good lateral image, and you can very subtly see that what should normally be the, convex surface of the lateral plateau is actually pushed to below the concave surface of the medial plateau. And I also look for associated like fibular head fractures, especially for certain patterns of plateau fractures that I don't see here.
Fantastic. Same thing I see. So just to kind of bring our discussion continually full circle here, is this something you're ordering a CT scan of, and why?
Certainly something I would get a CT scan for, especially depending on the patient, just to really quantify the amount of depression and the amount of joint surface that's involved, because some of these, and probably not this one, just given how depressed it looks on the radiographs, can be potentially treated non-operatively. And the other thing that I should mention on the lateral radiograph that is very important for everyone to look for is that even if the plateau fracture is more subtle, you can see there's a large hemarthrosis in the knee. And so anytime you see that, but you can't detect a fracture on the radiographs, you should be thinking like, is there a patella fracture I can't see? Is there a plateau fracture that's very subtle? Or could it just be that they have a ligamentous knee injury and that's why they have a hemarthrosis?
Yeah, so Lily did a great job of highlighting the fact that this person's got a lipohemarthrosis, which is evident on the lateral radiographic projection. And she caught that because she went through her skeletal anatomy and then was looking at the soft tissue shadows and picked up on that. So excellent job, and thank you for pointing that out.
The other thing, if you just go back one there, Luis, you can see the patellar tendon and you can see the quad tendon on an X-ray. You know, we love telling patients you can't see soft tissue on X-rays. When it's convenient for us to say that sometimes, but you can. You can see a patellar tendon injury with the patella proximal and some soft tissue defect there. There's a lot of soft tissue things you can pick up on even with an X-ray.
So when getting knee radiographs, we're typically getting AP and lateral views. And I want to point out a good AP is where you have anywhere from about 33 to 50% overlap between the proximal tib fib joint. So that's how you know the rotation of the limb when obtaining the image is correct. On a lateral, you'd love to see perfect overlap of the distal femoral condyles, which you don't see here. But I'm going to show you some images where you get a nice contrast. But if we do go back one slide, this is a great lateral where you basically looks like you only capture one condyle. It's because the medial and lateral distal femoral condyles are perfectly superimposed, where here they're a little off center. So this would not be a perfect lateral. The good news on this lateral is it shows us the medial and lateral plateau articular surfaces quite well. And we're going to talk about those here. So on the right, a good AP shows us the distal femur articular surfaces as well as the patella. And on the lateral, we're going to see the patella. We're going to see the medial and lateral condyles of the distal femur. And then finally, we're going to get a look at the plateau, which in this case, this was a plateau fracture. So we're going to focus in on that. On the AP, again, you're going to see the medial and lateral sides. And then on the lateral, as Dr. Stephenson had highlighted for us, the lateral plateau is convex, meaning it juts up, and the medial plateau is concave, meaning it juts down relative to the shaft of the tibia. And so you can actually see those shadows separately on a lateral and independently identify them on injury films and on intraoperative fluoroscopy when you're performing surgical reconstruction of a fracture. And then one of those specialty views we had mentioned earlier was that of a plateau view. And I want to show you quickly the difference between a regular AP, where the beam is just shot essentially orthogonal to the limb, versus a plateau view. So this is an AP, and I want to cue you into what the articular surface looks like, and we're going to see a comparison here in 2 slides, versus a plateau view where the beam is tilted, and you're shooting, again, down the joint and parallel to it, similar to the Grassi view we talked about in the shoulder. And this is the image you get with that plateau view where the articular surface of the knee becomes crisper. And this gives you a direct compare and contrast between the AP on the left and the plateau view on the right. Here again is a look at a bad lateral where you don't have overlap of the condyles, but what we are seeing here is nicely the medial concave plateau and the lateral convex plateau.
And I think this, the other thing about this slide is that, when you get a bad image in the operating room, or when you're in the emergency department and you're trying to get a better image and you get a little frustrated, use your context clues to know what you need to do with the limb. The image on the left here, that's a rotational. The condyles distally are at the right level. They're just internally or externally rotated. And then deciding which way to go can be a little more difficult to know, but that's a rotation thing. Whereas the image on the right, the posterior aspect of the condyles are totally lined up. So that's a adduction, abduction, or a wigwag, or a moving the leg in and out kind of thing that would allow you to get a better image there. So you can use your context clues of your bad image in order to get yourself to a good image quicker. So you're not taking 4, 5, 6, 7 different shots to try and get there. You can take maybe 1 or 2 extra shots to get closer.
Perfect. So just giving you all your dessert, here are some intraoperative images, reconstruction of this lateral depressed plateau fracture. I think this is a good case example of what a fractured articular surface looks like, what it looks like, what it's been reconstructed and placed back into an anatomic position, and then what your final fluoroscopic images may look like. Dr. Stephenson is working hard. She's on to her 4th consult in about 40 minutes. 47-year-old male fall off curb with ankle deformity. And this will be the last joint we talk about tonight. So we're cruising and we're right on time. What do we see here?
Okay, so we have 3 views of a right ankle that shows a short oblique distal fibula fracture, which is at the level of the syndesmosis. So it's a transsyndesmotic level. That's got some posterior and lateral displacement with associated tibio-talar subluxation. That's also posterolateral. And then we can also see just kind of subtly on the AP and mortise views that it looks to be to have an avulsion of the medial malleolus as well. In addition, there's a maybe small posterior malleolar fracture. And so this is one that after post-reduction radiographs are satisfactory, I would get a CT scan just to further characterize that articular component and make a plan.
Again, she's doing an excellent job of being precise in her description as well as concise. She's describing the displacement of the fracture by the distal segment as well as the displacement of the subluxation or dislocation. And I think this will just take a quick break and let Dr. Kellum tell us the difference between subluxation and dislocation.
Yeah, there's a great question there. Dislocation, there can be in my mind, no articular surface touching between the 2 bones that make up the joint. Whereas if there is a little bit of touching of the articular surfaces, but it's not concentric, then that's a subluxation. If they're completely not touching, that's a dislocation. And then there can be some very gray zones with some very significant subluxations that might be considered dislocations, but that tends to be the differentiation for me. I think the other thing I want to mention quickly just is that when limbs are fractured and subluxated or dislocated, it can be really hard to get a perfect view of anything, right? So sometimes you'll just get images that are a pseudo AP and a pseudo lateral to get you some sense of where things are. And that's the orthogonal views. You have a 90-degree view of the limb, so that then you can make a reduction, and then you can get a more appropriate AP, mortise, and lateral if it's an ankle. But you may not be able to get a mortise view or an AP view of the ankle, meaning that you may get a good AP of a talus, but then the tibia might be 30, 40 degrees externally rotated. So don't be frustrated in these subluxated or dislocated limbs if you can't get perfect images. It just gives you a sense of what you need to do to reduce it, and then you can get those images.
I think that's exactly right. And that's why it's important to know what the good images look like. As you reduce the limb, you should start seeing sort of return of that normal anatomy and radiographic parameters. In the ankle, we get 3 views typically, AP, mortise, and lateral. The AP you see here on the far left of the image does not give you as clean of a look down the medial gutter or really any look at the lateral gutter, as there's more tib-fib overlap. But once you get that rotated mortise view where the limb is typically inwardly rotated, you get a clean look down the medial gutter. You see the lateral gutter, or the space between the distal fibula and the lateral portion of the talus. And then finally, the lateral view. We'll go through exactly what we're looking at here, but a perfect lateral of the ankle will demonstrate a singular profile of the talar dome. So if you look here, just like in the distal femur, you want it to look like a very crisp, clean line, because the entire articular surface of the talar dome is parallel to the x-ray beams.
I don't know how you guys feel about the difference. This is getting a little bit into the weeds, but I think it's maybe good for the medical students. You know, I tend to think of the AP as a better look down the medial gutter, and the mortise a little bit better of a view down the lateral gutter. While the mortise does have a very clear view of the superior clear space, the medial clear space, and the lateral clear space, meaning the joint surface of the mortise, the trapezoid version. But do you guys feel that same way when you're using these images to help you, that's kind of your differentiation between the two, or am I totally way off base in saying that?
What do you think, Dr. Stephenson?
I guess for me, I prefer the mortise in general when I'm looking at the joint surface. I think it gives me a good view of both the medial gutter and the lateral gutter, but I typically use the AP as kind of like a corroboration of, like, if I thought maybe there was a posterior malleolus or Volkmann fragment versus a Chaput fracture fragment, I go back to the AP and I kind of look again to see, if I see a lucency on both of those views, maybe that's real. But
Yeah, I feel very similar, that I really like looking at the medial gutter on the mortise, Pat, but I know what you're saying about the AP and the medial ankle structures. I think it honestly gives you maybe a little bit better look at the medial malleolus. Not necessarily the joint surface or the articulation between the shoulder of the medial dome of the talus, but it does give you a great look at the medial malleolus in general. And both views do certainly provide value, and it's required and necessary to understand the difference between the two views. The dotted line here is just showing you the extension of the anterior distal tibia, where you end up with tib-fib overlap. Again, you typically have more tib-fib overlap on an AP, less of it, but still should be some present on a good mortise view. We get a good look at our distal fibula. It can even be seen on the lateral view as a bony shadow kind of projecting with the body of the talus. And then finally, the medial malleolus that's pointed out basically here on the AP view. And again, you can see a shadow of the medial malleolus on the lateral. It typically sits just proximal to that shadow of the fibula, which makes sense because if you look at the AP and the mortise views, the fibula extends more distal than the medial malleolus. So that shadow you see basically between the dome of the talus and the distal tip of the fibula is that of the medial malleolus, which typically has two colliculi, the anterior and posterior colliculi of the medial malleolus. And then one last thing I wanted to bring up that you can look for on the lateral is the posterior. Obviously, you can look at the posterior malleolus, but looking at the posterior border of the fibula, I think, is critically important because it gives you an idea of where the fibula is sitting relative to the tibia. And Dr. Kellum actually has a nice study looking at this in patients with normal anatomy, non-injured. That posterior border of the fibula should really transect where the articular margin of the distal tibia meets the non-articular margin of the posterior malleolus. That can have clinical implications anytime somebody has a syndesmotic injury and you're in the process of putting the fibula back to the tibia in an anatomic position. Here's just contrasting views of a lateral of the left ankle where you have a not perfect lateral on the left, and you see kind of two shadows of the talar dome and not that crisp singular line, versus the image on the right where you get a crisp singular line of the talar dome suggesting a perfect lateral image of the tibio-talar joint. This schematic is just depicting the difference between obtaining a AP versus a mortise view, where you're kind of on the AP looking at the tibia head on and then getting an internally rotated view with the mortise that again allows you to see a little bit more down the lateral gutter of the ankle mortise. And then finally, recognizing that the distal tibial plafond is not perfectly flat to the ground, much like the tibia. It has basically some slope built into it. And if you want to look perfectly down the ankle joint, that requires you, or look perfectly down the distal tibial plafond, that requires some tilt of your x-ray beam towards the head or cranial relative to the imaged segment of bone. Here's your dessert, a nice anatomic reconstruction of this ankle fracture with associated subluxation of the tibio-talar joint. So I hope tonight you all learned ways to identify perfect AP and lateral views of the shoulder, elbow, knee, and ankle. You need to remember the bony anatomy, as it will clue you in on what those x-rays should look like and what is abnormal. Hopefully you learned, and honestly, most importantly, how to describe fractures and dislocations of these body segments. Make sure when you're describing displacement of fractures or dislocated joints that you're doing so with reference to the distal segment involved. And then finally, appreciate all the other things you can learn on plain film radiographs. There's more than just the skeletal anatomy to be seen. On behalf of everybody at AO North America that's part of Link 3.0, I want to thank you all for joining us tonight, specifically Dr. Stephenson and Yang for being on tonight and providing their valuable insight, as well as my co-chair, Dr. Kellum. I hope this was valuable for you guys all. Our next lecture will happen on September 11th. I'm really looking forward to it. This is another one that was really coveted by the medical students and residents that Dr. Kellum and I engaged about getting a list of good topics to go over, things that weren't covered by Dr. Young and Mitchell with the previous versions of AOLink. And we're going to be going over implants and instruments on September 11th. So giving you guys kind of a glimpse into the OR and hopefully providing some familiarity with all of the different implants and instruments you may encounter in the OR taking care of fracture patients. So thanks again. Please don't forget to check your email for a link to this recording, and also as an opportunity to claim your Credly badge for this session.
Can I make one quick plug? I might say I liken imaging to AI, right? And the best AI platforms are based on the best data. So you want to inform your own personal algorithm by seeing as many images as possible so that you train your mind's eye to be able to say, hey, something's off on that image. And then you can investigate it further. And so thanks for tuning in tonight and getting, I guess, preparing your algorithm with some of these images, but continue to explore. There are some great resources on the AO website to look at how to read images and keep sort of seeing as many images as possible.
Yeah, to piggyback on that one, Taylor, I think that's a great point. But when you are on the trauma service taking call, we oftentimes do shakedowns or trauma exams, or whatever you want to call it, and we order thousands of different images of because there's a bruise or there's a scratch, and we want to make sure there's not a fracture, and we kind of know there's not a fracture, but we just want to make sure. Those are your opportunity to look at those films. You can't recognize abnormal until you know what normal is. And so the more normal films you look at, the more you can start to look at abnormal films and say, oh, that looks a little bit different. Obviously, the horrible fractures are easy to see, but as you start to see these abnormal subtleties, you only know that because you know what a normal film looks like. So as Taylor said, look as many films as you can, normal and abnormal.
Excellent. Thanks, guys.